Good afternoon, good evening, everyone. My name is Anna Chang. Welcome to UCSF Geriatrics Division Grand Rounds. We have a real treat this afternoon, this evening for us. I'm going to go ahead and get started. So Dr. Ted Johnson is professor of medicine, family medicine, nursing, and epidemiology, as well as associate professor of urology at Emory University. Dr. Johnson has been at Emory University in the Atlanta VA for 25 years, since 1997. Today, he is chair of the Department of Family and Preventive Medicine. He is the Paul W. Seavey Chair and Director of the Division of General Internal Medicine. He's a clinician at the Atlanta VA, and he's a scientist with the Birmingham Atlanta VA GRECC, that's the Geriatric Research, Education, and Clinical Center. And he has a successfully funded research program with more than 100 publications, and it's about appropriate and safe whole person care for older persons with a particular focus on bladder function with aging. Dr. Johnson is active in the American Geriatric Society. He's active in advancing social justice, and he is very active on Twitter at BaldheadTed. You definitely want to take a look. Dr. Johnson received his MD from Northwestern University Medical School and completed his master's in public health, his internal medicine residency, and his geriatric medicine fellowship at the University of North Carolina in Chapel Hill. Ted Johnson was born in Southern California and the first physician in his family. This was a career choice that won out over a career as a teacher, as he debated different jobs in high school. And today, Ted is a marvelous teacher and physician. Dr. Johnson has been a leader and truly the heart and soul of the Tidewell Emerging Leaders in Aging program for the past several years, and he has been teaching and mentoring over 100 junior and mid-career leaders in aging from multiple health professions about everything from financial literacy to organizational change. And it is in this capacity that I've had the great honor of getting to know Ted over the last years. Ted is a phenomenal leader, scientist, educator, clinician. I think they call someone like this who's good at everything a triple threat, maybe a quadruple threat. It's like a phoenix in academic medicine. But I just want to let you know that's not all. The most amazing thing about Ted Johnson is that he is an absolutely fantastic person. This is someone who's brilliant and humble and generous, kind, funny, authentic, courageous, full of integrity, and a tremendous role model. So I am really fortunate to know Ted. We are really in for a treat today, and we wish we could see you in person, Ted, but we're sorry that we can't. And instead, we'll extend our warmest UCSF Zoom welcome to you. Thank you so much for being here.
Thanks so much. I couldn't be happier to be here with an introduction like that. I'll come back again and again and again. I'm very appreciative to have a chance to have time with you together tonight. And so many friends here that I've known for quite some time, as well as new friends that I'm making today. And so I really appreciate my opportunity to have a visit with y'all. So I'm going to go ahead and share screen here, and let's get started. So this is about being on the losing side of a vote. And so the title is FDA-Approved Antidiuretic Therapy for Nocturia being outvoted 4-14. I hope to share several of my experiences of being on an FDA advisory group and actually being recorded making a vote. And I can't lie about what I said because it's actually recorded and on the web. So I hope to engage you in some audience response. And so I know that this is a little bit harder on a Zoom platform, but I encourage you to scan that poll everywhere, or if you have poll everywhere already on your phone or device, you can subscribe to Baldhead Ted, and that'll allow you to answer some of these questions as we go on through tonight. I hope to just engage you in some discussions about FDA advisory panels, what a typical patient with nocturia or nighttime voiding looks like. I want to talk about the hormone replacement therapy Desmopressin and talk about why that should be a concerning medication in the types of patients that we treat who are older with multiple comorbidities and perhaps even some renal dysfunction and cardiac dysfunction. Wanted to just engage you in discussions about how you treat hyponatremia, one of the main side effects of the use of desmopressin, and also wanted to engage you with some thoughts about how we monitor them. So before I get too far, I've really been informed by my colleagues here at UCSF, and they have read things that I've written. They've been editors of papers that I've submitted. Many of you are clinician experts as well as thought leaders. And I wanted to start off with saying that desmopressin is the lawn dart of pharmaceuticals. And by the lawn dart of pharmaceuticals, I mean that it's kind of catchy, it's fun to do, and it's inherently dangerous. And so for those of you who don't remember lawn darts from the 60s, 70s, and maybe even mid 70s, early 80s, this was a game that was produced and sold by the Sears Roebuck Company. Looks like a lot of fun, except these darts weigh about 5 pounds and they have steel points at the end, and who knows what problem could go wrong. Lawn darts are a lot of fun. Are they inherently dangerous? Yes, they were removed from the market, but there's a secondary market in lawn darts, as well as some instructions online about how to make your own lawn darts. And I think desmopressin as a drug is the lawn dart of drugs, inherently worrisome in our senior population, and yes, kind of intriguing and seems to be designed in a good way. But something that I don't prescribe, and something that I'll talk to you more about as we go on, the lawn dart of medications. The other thing is that I'm going to talk to you about my participation in an FDA hearing where the drug that we ended up as a group recommending to the FDA that it be approved despite my vote, this drug is already in bankruptcy, and so it's not available anymore. And so kind of is this a talk about another nail in the coffin of a drug gone awry? Or is it a cautionary tale to think about, what's happened since then? And to every effect, there is an equal and sometimes disproportionate other effect. This, if a butterfly flaps its wings in one side of the globe, does that create a weather disturbance on the other? And I would posit to you that some of the weather disturbances that we've seen from Noctiva's or intranasal desmopressin, Noctiva's approval by the FDA created a lot of other wins that have been felt and will be felt. So let's talk about some continuing education disclosures that I offered. One is that I do some research with continuous glucose monitoring in the long-term care field. Won't touch on that today. I've also worked with Medtronic about some home COVID monitoring protocols. Won't talk about that today. Interestingly, as I was getting ready to prepare this talk, I got some disclosures to mention about the FDA. This is like in a totally separate environment than the FDA talk that I'm talking to you about. But just to be clear, the FDA sponsors something called the CPATH Drug Repurposing Collaboratory, and I'm involved in a study that is looking at treatment of long COVID with already approved drugs. I don't think that any of my involvement with repurposing of drugs will have any effect on what I'm about to tell you about my experience as an FDA panel member. I have in the past worked as a consultant for Astellas and Asahi on products that are unrelated to this. And so I think that you'll find that that won't mean for you a significant conflict of interest. Outside of the kind of defined time period for conflicts of interest, I want to disclose some other things, and that's that I was a member of what's called BRUDAC. You'll see it there. I also receive royalties from UpToDate because I write the target card on Nocturia. And so if you have access to UpToDate, and if you do it, if you're at the VA for sure, you can look up Nocturia treatment in adults, and I wrote that. I used to consult for Ferring, and I quit consulting for Ferring on their nocturnal Nocturia products based upon my concerns over their overall safety. And so I'm more of a skeptic than an advocate. And so again, the lawn dart of pharmaceuticals. The other thing is that I worked with a company called Vantia, who has an interesting product called V2 receptor agonists. And I'll talk to you about what those are and what they do. And largely for them, I helped design quality of outcome measures for Nocturia. And I've also worked with a company that was looking at patient-reported outcomes in Nocturia. And my contribution to that was looking specifically at older adults and what their different experience was of Nocturia. And it ended up being two things. First of all, Nocturia makes people feel that they're older because they associate it very heavily with being older. And secondly, that people with Nocturia who are older have a fear of falling that is not experienced by younger individuals. So here's some learning objectives that I submitted, and we're going to cover all of these. Want you to understand through this lecture aspects of the drug approval process, to describe concerns that are regarding the mismatch between people who are in this project versus people who are the folks out there with Nocturia. Examine the impact of pre-authorization and formulary restriction. The headline there is that most of the medications used are not these branded approved FDA drugs, but actually older generics that are cheaper. And I'll tell you more about that later, and just give you a view of drug safety. So thinking about audience response, hopefully you got that QR code and can scan, or you can text baldhead TED to 22333, or you can respond on the computer at polev.com/baldheadted, easy to remember. And so I'm gonna look for you to go ahead and respond with the first question, which is just a test question. And that is, what is the name of my daughter's dog that is pictured here? And so I'll look and see if we've got folks. Oh, hey, great. We've got folks already chiming in. That's awesome. So 6 results on my daughter's dog. All right, we're just gonna let these results come in. Biscuit is a close second. Cooper is number 1 at 38%. Biscuit making a run there. Okay, sounds good. Let's see if there's any more people chiming in. All right, so we'll call that poll closed, and it is a tie between Cooper and Biscuit, and one of those answers is correct. So that's good. My daughter's dog's name is Cooper, but the first time I gave this poll, it was Biscuit. Biscuit was the clear winner, and so we're going to begin to call her dog Biscuit. All right, so let's do an SBAR here: situation, background, assessment, recommendation. We'll start with the situation. Noctiva is approved by the FDA. This is the room where it happened. And so in contrast to Hamilton, the musical room where it happened, this is a public room. And so everything we said was recorded and transcribed and appears online, and I'll show you where to find it. So it's not some secretive process. There is an opportunity for folks to be an ad hoc member of panels like I was. There is an opportunity for folks who even might have done some consulting in the area, might be approved as I had. And then the other thing is that there's an opportunity to show up in Bethesda and actually make a comment from the audience. And there are 2 AGS members who did, and I'll tell you more about that later. All right, so here's our second engagement slide. So which is true with regards to FDA advisory committees? The advisory committee is constitutes official position of the FDA. Interested parties in serving on an advisory committee cannot self-nominate, but rather they need to be nominated by someone else. The FDA designated federal official chairs the meeting. Committee input may involve general topic advice beyond the specific product, or financial advisors' financial interest disclosures are sealed and cannot be viewed by the public. And so let's see what folks have to say about that. Thanks for responding. Okay, very good. And that is a correct answer. The committee input from an FDA advisory committee may be broad general topic advice across multiple products. And I think that one of the things that I often ponder is that our vote on Noctiva paved the way for other drugs in the Nocturia space. And I'll tell you about why I think that that's a concern. The FDA designated federal official is a chairperson of the advisory committee, someone external who actually chairs these meetings. And the official position of the FDA actually happens after the meeting. And so some of the things that we recommended actually didn't happen in the labeling because the FDA got together with the company and made different recommendations, which was very interesting to me. And advisors' financial disclosures are open records. And so you can go and find out where and what they are. So if you have more interest in finding out more about the FDA Advisory Committee, you can scan this QR code and go to this website. You can actually self-nominate to be on an advisory committee. When I walked in the room and told them what I was doing and what I had experience with, they're like, we need more geriatricians on the committee. True fact, unsolicited. That's what they told me when I told them who I was. The members are scientific experts, consumer representatives, industry representatives, and a rep from the FDA who's a patient rep. And basically, you get an opportunity to share your views during the hearing, and it's part of open and transparent government. So encourage you, if you have some topic expertise, if you have an interest in being a public advocate, there are ways to participate in this process. So here's the punchline. So one of the things that happened is that question number 6 here was the one that we voted on, and I was in the minority in voting. I felt that Noctiva Desmopressin nasal solution actually had more risks than benefits, or rather that the benefits did not outweigh the risks. And so there are 14 people who voted forward it, which led to endorsement of this product and subsequent marketing and labeling of this product. The interesting thing that I was talking about with some of you today is that of these 6 questions that the FDA asked of their experts, I don't know the answer to all of these. And I didn't know the answer at the time. And part of what I've spent the last couple of years doing is actually doing the research that answers these questions. And I hope to show you some of my work and some of the work of other people that has really helped us begin to answer these questions. And why is this important? I think that there's the FDA Advisory Committees and the FDA approval process are in the news a lot, certainly with aducanumab, and trying to figure out how did they come up with that and what was the process here. And I think that some of this comes down to the questions that the FDA asks of their advisors are the right questions, but actually the knowledge to answer these questions lags behind. So here's question number 6. This is the in the title. I voted no and was outvoted. And so the question that was posed by the FDA, and they asked you to answer it in the mic and explain yourself. Do the benefits of desmopressin outweigh the risks and support approval? I was kind of sold on the benefits, and I'll tell you more about that why, but I was not sold on the risks. And so I voted no and provided an answer. And here's my answer. Hi, this is Ted Johnson. It's kind of funny. I voted no. I believe that the risks outweigh the benefits in the oldest old and those with multiple comorbidities. I think that the combination of a poorly adherent patient plus an inadequately educated provider is potentially dangerous. I've had people who have taken once daily drugs and on their own doubled the dose and or taken them twice daily. A combination of nighttime, and this was the name of the product that was being voted on before it became Noctiva, Sert 120 with the morning Sert 120 would be devastating. And I share that. I actually asked during the meeting for information about older adults that were included in the clinical trials. And the person who is CEO of the program said, we'll get that to you. Of course, we'll get that to you. That was in 2016. I'm still waiting for them to get that to me. And they certainly didn't get that to me by the time I had to vote on this. And so I think that the lawn dart of pharmaceuticals is such that the Swiss cheese holes line up. The patient doesn't understand what they're taking. They decide to drink more water because they read something on the news about drinking more water. The physician doesn't know exactly how often the provider, the physician, the nurse practitioner, the PA doesn't know how often to take the sodium values. The patient is seen in the ER with hyponatremia, gets IV fluids, but the drug is continued. The patient starts a diuretic along with the antidiuretic based upon another provider who's not involved in the decision to provide desmopressin. And I think that this is the lining up of the Swiss cheeses. And I think that that's why people get in trouble. I can't prove it, but I think that's why people get in trouble. All right, so we got to the punchline of this talk first. It's a lawn dart. I voted against it. I don't think it's a safe drug. I don't use it myself, but let's go back to the beginning and let's give you some more information about Nocturia and Noctiva and other desmopressins so that we can talk more about this. So let's do another engagement poll. The typical patient with Nocturia is A is male, experiences moderate to large bother. B has one principal cause of Nocturia. C developed Nocturia over years. D, and will have a 3-episode reduction if they're treated appropriately for Nocturia. All right, and results are coming in. Thank you so much for participating. Okay, so let's go ahead and lock that poll. Thanks for voting. If I'll watch and make sure that I'm giving you enough time to vote. The typical patient with nocturia is male if we're talking about patients who are over 70, but actually in the 40 to 55 range, it's actually women who more often have nocturia. The typical patient with nocturia, I'll show you some breakdowns of numbers of episodes of nocturia and bother. Most experience no or low bother from this problem. This is a group of geriatricians who are savvy about multimorbidity. It is not true that patients have one principal cause of nocturia, but the urologists keep designing, not to pick on them, they're my colleagues, I have an active appointment, but the urologists often create this flow sheet that shows how you pick the cause and go down and find the treatment. And it's like, okay, this person has 5 different potential causes of nocturia, and so how do I go down this flow diagram? Yeah, correct. Most patients with nocturia have developed this over years. They've developed compensatory strategies. They've tried some at-home behavioral monitoring and interventions. And sometimes they do things that are helpful and sometimes not helpful. And this is a very resistant to treatment condition. It's not a condition, it's a symptom. If you identify a principal cause and thinking about obstructive sleep apnea being a principal cause, that you can really hit a win with doing CPAP therapy overnight for nocturia. That can reduce it significantly in many, but oftentimes we're knocking around the edges. We're getting on average over a week's time, maybe 0.3, 0.5 episodes of reduction of nocturia. One of the problems in clinical trials is that the placebo group keeps doing better. Is that because they're regressing towards the mean, or is that because there's a monitoring effect of doing all these diaries? I'm not quite sure. So one of the contributions that I made that was facilitated through my participation with the Fairing Company was to actually participate in a nocturia definition exercise. Before that time, we were talking about nighttime voiding. We were talking about voids between noon and 6. We were talking about voids between 7 p.m. and 7. And so we began to see coalescence of the nocturia definition around linking it to sleep, mostly nocturnal sleep. This extra clause in the 2019 definition talks about the fact that you can have nocturia even if you don't go back to bed and it didn't interrupt your sleep. If you wake up at 5 a.m. to go to the bathroom and you can't get back to sleep, but you wanted to, that is a nocturia episode in this definition, but hadn't been before. It's not a disease, it's a symptom. If you have an accident in the bed, that's enuresis and a different problem. And the nocturia definition includes even having this once per night. And we'll show you some data that shows that once per night is really not all that bothersome. It turns out to be 2 times a night or more that causes problems. So my good friend Kari Tikkanen, a Finnish urologist, epidemiologist with whom I met at an American meeting, said, I like your work. And he said, I like yours too. And so we worked together. It was a lot of fun. And so the first thing that I read of his was, do men or women more often have nocturia? And you'll begin to see that this changes, as I suggested, maybe a little bit earlier than I suggested, with women in their 30s and 40s having nocturia. And then by the time you get to be 50s, it's more often men with total episodes of nocturia, but women still having 2 or more episodes more often. And then by the time you get to men in their 70s and 79, his Finnish epidemiology study stopped at age 79. So we don't have data to show how much more common this is in the 80 plus group. But that's about what the prevalence is. If you talk about 2 or more times at night for the 70 to 79-year-olds, you're talking about 30 to 40% for women, followed by men. So that's how often this happens. And so a little bit of a complex diagram, a well-cited article by Tikkanen in the European Urology. I was the second author on this paper and proud to be so. Basically, he anchored nocturia and episodes of nocturia to the 15D. And this kind of tagging and experience to a quality of life instrument sort of showed that 2 was different from 1. 1 was not all that different from 0. And 3 was definitely worse than 2. So this is a quality of life problem for folks who are having more episodes of nocturia. It seems that 2 is very different from 1. And since 1 is so common, most of the pharmaceutical and behavioral and clinical trial strategies have focused on this 2 or more group. All right, so I had the good pleasure of coming into some VA cooperative study trial data, and we basically took a composite endpoint of BPH, benign prostatic hyperplasia symptoms, based upon the American Urologic Association 7-symptom index. And of those 7 symptoms, the 7th one is nocturia. And so I wrote to folks at the VA Cooperative Study Office. I say, you have these data that can actually, we can decompose this composite variable and look specifically at nocturia. Nocturia ends up being a great variable to peel off of the AUA 7 score because it is a count variable, whereas others are frequency. Do you have this? Not at all, 1 in 5 times, less than 1 in 5 times, about half the time, et cetera, et cetera. And so the nocturia variable handles really well. Interesting thing, we were talking about this before. Do most people have moderate or severe bother? Here's moderate, here's large. A lot of folks have just really no bother. This is 0 episodes, but people have no bother all the way up to 5 episodes. It's not so common, sorry. But if you look at kind of the preponderance of where numbers are out of these 1,200, there's a lot of folks who are in these none, very small, small. And it's the preponderance of folks who are experiencing moderate or large bother once you get to about 3, 4, or 5. And again, if you look at the 2 or more, there's a lot of people who are over here with none, very small, or small bother. Let's do this a different way graphically and show you kind of a stacked bar chart that totals to 100%. You lose the fact that there are 1,200 respondents here, but you can see what each respondents were saying. And just there's something different about large and moderate bother with 2 or 3 episodes versus very small or no bother with 2 or 3 episodes. And we've decomposed this and looked at this in a couple of clinical trials and looked at this in a couple of epidemiologic trials. And not surprisingly, these high bother people are folks who feel fatigued in the morning. These are folks who have difficulty getting back to sleep and have daytime sleepiness. So I'm beginning to make this case for the bother in nocturia is sure it's episodes of nocturia, but it's also this sleep intersection, and the intersection between sleep and nocturia is ripe for some combined behavioral therapy work that's being done here at UCSF as well as UCLA and as well as Emory. I just wanted to tell you that I wrote the up-to-date chapter, and basically I break down what causes nocturia by things that cause you to have low volume voids, sleep dysfunction, and peeing a lot at night. And it's peeing a lot at night that is the treatment target for antidiuretic therapy. I suggested that this is not an entity where we looked at 55 men and categorized them based upon standard definitions, folks that we saw clinically, and they have a lot of potential causes for nocturia. And this notion that you just find nocturnal polyuria, you treat them with an antidiuretic and they get better, that's probably not how this all works. And that there is this risk factor synergism, and that you use targeted interventions to get this better. Peter Augrey won the Nobel Prize in Chemistry in 2003. I had a chance to meet him when he came to Emory to give a talk. Really awesome guy. Basically showed that red blood cells in a hypotonic environment with aquaporins will actually burst as water moves into the cells. But if there are no aquaporin deficient RBCs, they will not allow water to come in. And so water is very slowly transported via bilayer diffusion, but is rapidly transported with aquaporin channels. And there's a 3D structural representation of what these aquaporin channels look like, and they let water flow through freely. And basically what you're doing with desmopressin is it's stimulating this V2 receptor, which causes a number of cellular changes, which moves vesicles to the, I believe, luminal surface. And so basically the effect when these aquaporin cells are in the distal collecting tubule is that free water actually moves back into the kidney and out of the collecting tubule. So you are producing a very, very concentrated low volume void. And as the desmopressin actually wears off, then you go back to producing a normal concentration urine that is actually more dilute because you're actually getting really free water during the night. So let's talk about some of the questions, other questions that were asked of us at this FDA hearing. And I've got one more poll coming up for you here. What percentage of adults with nocturia who are age 80 or above have contraindications to desmopressin? And I'll tell you what those contraindications are in a second. But just basically saying this lawn dart medication is probably not safe to use in these 80-year-olds. And these contraindications came directly from the package insert. So I'm not making anything up. I'm just reading what the FDA said. So let's see what folks say. 63% of 80-year-olds have a contraindication. No one's falling for the 22%. I appreciate that. Some folks saying that 95% do. And so let's go ahead and close that poll there. And so the correct answer is 73%. So 73% of US adults, if you just read the package insert and you match them up to an NHANES sample of folks who answered a nocturia question and had a complete physical and laboratory studies, basically 73% of 80-year-olds with 2 or more episodes of nocturia actually can't take this drug based upon the package insert. Here's a link to this article. Kara Suveda was an MPH student at the time, did a bang up job with these data. Laura Planting, a former UCSF alum, worked here for a while in general internal medicine, was the second author. They contributed equally to this. And so really proud of this work. That it took me a long time to be able to answer a question that I was asked in a 1996 meeting, but I think we did it. For 50-year-old and older and above, 4% had low sodium, a contraindication, 10% had a low GFR, 7% had CHF, 20% took hydrochlorothiazide. Hydrochlorothiazide is listed as a precaution, but actually an international expert panel said that hydrochlorothiazide was a much more problematic medication for hyponatremia than was a loop diuretic. And so we're going to run these data with the international guidelines panels rather than the package insert. And poor control of hypertension, this is a loose definition. It's greater than 140/90 based upon NHANES's definitions of poor hypertension control. So there is a vasopressor effect of vasopressin, the native hormone, but the synthetic desmopressin hormone that's modified from vasopressin shouldn't have vasopressor effects. If you break this down by age, any contraindication, a third 50 to 64, over half 60 to 79, and greater than 80, 73% as was answered. Those are point estimates, and with the weighting of the samples that's done in NHANES in these cross-sectional data, you can get a sample weight, 95% confidence interval based upon these data. Very simple analysis to do, very difficult to go back through and code all these variables and line everything up, but a great job by Suveda and Planting. So the benefit is that if you take desmopressin before bed, you produce a concentrated urine at night, the drug wears off by dawn, and you have a daytime diuresis, and you get a good night's sleep. Maybe. The effect size I'll show you in a minute. It looked like versus placebo. The active drug 1.4 reductions in nocturia episodes versus placebo 1.1. So really a 0.3. In my experience and in my hands, when we've done trials with interventions for nocturia, the placebo group or the non-intervention arm always does really well. And this is true in a lot of urinary incontinence, lower urinary tract symptoms work, and nocturia work in particular, is that the practice of recording this and the practice of monitoring actually changes the phenomenology. And so it's a real problem to demonstrate that there's a robust effect when the placebo tends to benefit as well. I think that's because the placebo is actually an intervention, but maybe that's charitable. So here's where the harm comes in. If the drug remains active past dawn and you continue to produce a concentrated urine, you can have free water accumulation and you can have hyponatremia side effects. More often than not, since I've used this drug in research settings, you're producing hyponatremia that's first detected by drawing blood for monitoring. So interesting. One of the debates that we had was this issue of, whether or not we could actually recommend a single dose to use. Lower is probably safer, and lower wasn't efficacious. And so the two trials tried two different drugs, and one of the trials tried 3 different doses of the same drug. And so it was only the highest dose that met both primary efficacy endpoints. Interesting, if you look at what was happening with desmopressin formulations, whether it was pill or injection or nasal spray or sublingual lozenge, it remained true that you couldn't get the effect that you needed to have a powerful trial, a positive trial, without pushing up the dose, which drives down the side effects. And so here it is again, 1.5 versus 0.75 versus placebo, minus 0.4 episodes of nocturia, minus 0.2 in the second trial, minus 0.3, minus 0.2, not overwhelming. I did a secondary analysis of the VA cooperative study data. As I suggested before, I found out that the net benefit of tamsulosin in patients with BPH and the effect on nocturia is about 0.3. So that's placebo controlled, and that's the net difference. It was 0.6 versus 0.3 in the placebo. And so we keep seeing this 0.3 come up again and again and again. And so I'm not sure that this is a drug that doesn't have a statistical efficacy. I'll show you about clinically meaningful reductions in nocturia in just a second. Let me try this with you first. If you think about therapeutic window, and I talk to my patients about that a lot, I say, I gave you a drug. Did you take it? Yes, no. Yes, I took it. Did you find that it helped you with the condition? Did you have any benefit? Yes, I did. Okay. Did you have any toxicity? No, I didn't. And so sometimes I can tell that I'm in this green therapeutic window by the absence of toxicity and that there was a desired effect. I'll tell you the problem with desmopressin for nocturia, and you're not getting to a therapeutic level over time. You're actually repeatedly dosing something that you expect to wear off, and that the concentration will go down to 0 again before you give the next dose. And so the desired effect is that you have this narrow time in a therapeutic window from 4 to 6 hours on Monday night, on Tuesday night, on Wednesday night, on Thursday night, on Friday night, and that they don't dose stack, meaning that you don't begin to move out of this therapeutic window or stay longer in this therapeutic window, because the natural outcome of having prolonged desmopressin, vasopressin levels in the body is that the body will continue to produce a concentrated urine. And so that's basically the syndrome of inappropriate antidiuretic release. That's SIADH here. So if there's a desired nighttime antidiuresis, you've got to have a compensatory daytime diuresis. Otherwise, you begin to get bad effects of this. So I think we're asking a lot of this strategy. I think that this is shooting through a very narrow needle. All right, so let's do this engagement question. Per FDA labeling, ongoing monitoring for low sodium, ongoing monitoring meaning you've already successfully navigated the 4 dose checks during the first month, and you're looking at ongoing monitoring. The 4 dose checks during the first month, prior to prescribing, 3 to 7 days after prescribing, and within that first 30 days, I guess three doses there. And so then the question is, how often should you be monitoring for low sodium with desmopressin according to the package insert? You're going to hate this answer. Here's what the package insert says: periodically. What does that mean? So I told you that I wrote the card for Nocturia. So the updated editor said, hey, we just got this medication approved that we want you to write and describe what the monitoring protocol is for it. And I was like, you don't understand. The manufacturer didn't specify a monitoring protocol. Well, what do you think it should be? I think it should be as often as needed. All right, so what does it say in the package insert about somebody with more, with a greater risk factor of having hyponatremia? What does it say there? It says periodically, and then it says for people at high risk more often than periodically. So you tell me how often, more often than periodically is. It's just one of those holes in the Swiss cheese that will line up. There's no description other than periodic monitoring. So Noctiva can cause hyponatremia, which can be life-threatening. We've had some way back when we were doing some clinical research units. If you stack your water deprivation test and DD-AVP aqueous administration, followed by a water loading test, you will develop hyponatremia. And so if people change their fluid intake pattern, it's bad, and it can be life-threatening. So so monitor more frequently than periodically. Not helpful. All right, so let's talk about some recommendations. All right, are we kicking a drug that's already dead? And what's the point of all this? Is this just my post-traumatic stress disorder from not knowing the questions that I really couldn't know? And I didn't think that there was anybody else on the panel who knew the answers to the questions that the FDA was asking us as the advisor. So how much concern should we have? All right, so let's just do a quick check. The approach to mild asymptomatic hyponatremia from desmopressin is to stop the drug, supplement sodium, monitor for symptoms, watch for weight gain, or hold medication for one night. It turns out that the 100% correct answer is to stop the drug, or you could reduce the dose of the drug. Symptoms of hyponatremia are notoriously late. You can get weight gain, you can get lightheadedness, you can get headache, but notoriously those are late effects. Interestingly, one of the patients who developed severe hyponatremia during the study with close monitoring of the pharmaceutical company went to the emergency room, was loaded with IV sodium and discharged back to on the medicine and developed hyponatremia again. So it is not beyond my imagination that even people on the drug trial monitored by the drug company don't get the wrong treatment for hyponatremia. And that's not a knock, it's hard. I mean, we don't use this medication. Maybe if you're a hematologist, you do for von Willebrand's factors disease or for bleeding in renal conditions, but otherwise not. So this was a Freilich who wrote an opinion piece viewpoint in JAMA and said that, hey, look, this is a worrisome drug. We really ought to worry about this. All the deaths were in the active drug side. Hyponatremia in highly selected patient population with close monitoring. These were people, as I showed you from the NHANES, are not people in the public with Nocturia. Committees members concern use of patients and populations excluded, nursing homes and patients underrepresented. Hey, he cited me. That's kind of nice. And so, yeah, I had that concern and continue to have that concern. So here's a question that you don't have to answer. What chance of dying would you be willing to accept to have 2 fewer episodes of Nocturia? And I think that most people would say, put that way, 0. I'd accept 0 chance of dying to deal with Nocturia. So there's Nocturna, which was released right after Noctiva. This was for a Ferring product. Ferring was actually kind of excited that Noctiva was approved because they had tried twice earlier, maybe 3 times, to get different either pill formulations or sublingual tablets approved by the FDA. And the FDA always tripped up on the meaningfulness of the effectiveness, and they actually meet and were equivalent to Noctiva's, and so they got approved. 95% of the use of desmopressin formulations is in older generic formulations. Have we developed a safer drug? I don't think so. I think it's still a long dart. Have we developed a drug that might be might potentially have some better properties because it's a sublingual controlled release tablet? I don't think so. But the fact is that if you look at Medicare Part D authorizations of unique individuals who received desmopressin formulations, the majority of them are receiving older off-brand medications that have been around for 20 years. And so these are data that we published in JAGS last year. And so I think that people are being driven to these newer drugs by advertisement, and they're being driven back to the older, worrisome formulations by pharmacy benefits managements and formulary choices. And I don't fault them for picking a bad generic drug over a likely bad, expensive drug. So these drugs haven't really taken off. These are data, and I just checked these, the 20 data are not all that different. And so basically these drugs being used by about 800 people nationally in Medicare Part D. If you look at something like an alpha blocker used for BPH in this population, let's take tamsulosin in its various forms, it's about 3.2 million users. And so this is really small use of this drug, but it's 40,000 users of people who are using the older formulation. So I think that the marketing on the branded formulation is driving demand for the older. Some other data from Freilich and Plus One. I gave you this link. It's free, a paper to look at. He basically said, so outside of clinical trials, what are we seeing in terms of hyponatremia? And basically he compared desmopressin to people on oxybutynin, not a great drug either, but an anticholinergic drug. So it's suggesting that these people are also doing something with lower urinary tract symptoms. And so this is about 13 times the risk of having hyponatremia being on desmopressin versus oxybutynin. There is some natural rate of developing hyponatremia, perhaps due to some other drugs, but not due to the oxybutynin. Getting to the end, I wanted to show you this treatment benefit scales. How do you come up with the minimally clinical important difference? You anchor the treatment trial results to some sort of quality of life metric. And if you look at treatment benefit scale, my condition is now much better, somewhat better, not changed, somewhat worse, much worse. We'll look at the average change in Nocturia to get into these much better or somewhat better categories, and not a hopeful response. You have to have 2 episodes fewer of Nocturia per night to categorize yourself as much better, or minus 1.2 on the somewhat better. This is not the net difference. This is the gross difference. And so maybe some of these people got somewhat better, but if you look at the net difference, reduction in Nocturia of 0.3, 0.4, we're just nowhere close to these, this drug strategy making people just a lot better. So we'll finish back up with the learning objectives. Wanted to walk you through kind of understanding aspects of what this drug approval process looked like that I got to participate in. And I hope that you'll take up an invitation to nominate yourself or a colleague as a geriatrician, as a gerontologist to serve on one of these panels. The mismatch of the population and the trial enrollment was profound in my view. People who were in the trial had no contraindications, and we found 33% or 50% or 73% of people of ages who are normal, healthy participants in NHANES had contraindications to these drugs. I think that pre-authorization and formulary restriction is driving the few people who are taking up the opportunity to do this strategy to older formulations, which are likely just as dangerous, and just some thoughts about drug safety. So great appreciation. Whenever I was talking about things that we did, this is who we was, and indebted to folks who helped in this work, and it really does take a team. So thank you so much. I'll go ahead and close down the slides, and I'll turn it back over to Dr. Walter to lead us through any questions or comments that you have. Thanks so much. I really appreciate the opportunity to be here.
Fantastic, Ted. That was just terrific. We do have some questions. One question is, what is the time commitment if you nominate yourself for an FDA Advisory Committee? Like, how much time are we talking about? Or I'm sure there's a range, but sort of in general, what is that like?
Well, if you did it like I did and they mailed you the information packet to the VA, it doesn't take any time to prepare because the packet arrived after I returned from the hearing. So there was not much involvement, and they wouldn't send me any information over email, which was just really discouraging. Having said that, I think that if you took a look at all the materials that were there and recognized that what you're asked to do is to listen to in-person hearings, which takes about a day, and review the packet of materials beforehand, which would probably take you 2 4-hour periods over 2 nights, I think you'd be well prepared to be a meaningful member of the panel.
Great. And I assume a lot of this is virtual now. Is that so you can do it? Or
Yeah, honestly, I've lost track of whether they're doing in person or virtual. I would assume that they're doing several aspects of it virtually, but I bet because of the nature of the process, they're going to try and get back to in person as soon as possible.
Okay, great. Also a question about the fact that the unrepresentativeness of the trial participants.
Oh
The
gosh.
FDA moving towards any type of requirement to include people over 80, or at least try and better match the trial participants to who actually takes a medication?
I think that this is a great voice of gerontologists and geriatricians in the process because the NIA has an initiative to make sure that there's inclusion and representativeness in trials. I think that it could be a lagging requirement by the FDA, meaning that we're going to see this in new applications that come up in 2 to 3 years. But I was just so discouraged by that people to get into this trial had to be so unrepresentative so that the performance of this drug in real world settings is just really unpredictable.
And I see some people have their hands raised, but please put your question in the Q&A. All right, so we have a question here from Dr. Grouden, and he says, the Swiss cheese model of drug harms has inherent appeal to the mind of a geriatrician. Do you have any sense of how it was viewed in your FDA testimony?
I wasn't clever enough to have thought of it at the time of the testimony, but I think that that's where I ended up thinking about it a lot afterwards. I think that the Swiss cheese model is really good. It's a great it's a great representation of how this lawn dart drug can go bad. It's not the majority of people will have problems, but some people, a small percentage, will have very bad problems. And one of the things that I'm very interested in, and I talked to several of you today about this, is that you do all this evaluation to figure out whether or not a person should start the drug, but how do you figure out whether or not there aren't conditions that have emerged during treatment that are now contraindicating? And is someone thinking to go back and say, oh, this person just got put on a hydrochlorothiazide by somebody else, or, oh, this person is developing congestive heart failure and is now under treatment for that. I should be aware of all the other things that are going on in this patient and remove them. So I think that the Swiss cheese model is a really good one for that, and wish I had thought of a lot of things to say while I was in the room. Hopefully by showing you some pictures and describing the process and you being informed consumers, you can go and not be as starstruck as I frankly was.
Great. We also have several comments from Dr. Schwartz, who talks about she co-chaired a workshop on roadmap to the 2030 evaluation of new drugs in older adults that was in JAGS, and proposed proportional enrollment to age distribution of patient populations. I don't know if you've heard anything on that or comment on that.
I love that. I love that idea. I think that that was not happening in this hearing, where they accumulated as many middle-aged and young old as they could and considered that to be a diverse population. I didn't think that that was true at all.
And then she also puts here that depict ACT or ACT is being proposed by Anna Issue. So anyway, she apparently there is some thoughts to trying to make this better.
Yeah. Thanks so much for that. I know that Ferring, the manufacturer, published 21 articles on Nocturia in the month of January, most of them in a special issue of European Urology Focus. And so we need to be together as a team and as a group of concerned individuals to begin to collaborate and to pool our resources to get the appropriate trial designs that we need for therapies that are largely going to be used in older adults. So thanks for that. That's awesome.
Perfect. And then another question is, in terms of what do you recommend as the standard workup for nocturia? Because obviously, since there are so many different causes, whether the drug like tamsulosin or what that's going to depend. Well, is it due to BPH or is it due to something else? Is there sort of something that you recommend if someone presents to you with 2 or more episodes of getting up at night to urinate? What do you recommend in terms of standard workup?
Yeah, I'll give you a very shorthand for this, for things that you might not have thought of. I'm looking for peripheral edema that's actually more common than you might anticipate, and something that's not your kind of do an H&P type of thought. I don't think that, I don't treat men with finasteride or dutasteride or 5-alpha reductase inhibitors unless I have evidence that their prostate is large. Repeated trials have shown that that's not a useful strategy in men with prostates that are 30 grams or smaller. And so I'm either hoping that there's a PSA in the chart so I don't have to order a PSA in an older person, or even a digital rectal exam for prostate size. The other things that I'll say is that I'm using the Berlin questionnaire to try and find out some information about snoring and sleeping and daytime somnolence, because you could sit there and pound away on the bladder and the prostate and then may have missed something that's a sleep related problem. I'll tell you that in our trial of 55 consecutive veterans that we tried to do a multi-component intervention for Nocturia, while epidemiologically hypertension and epidemiologically diabetes are important risk factors for the development of Nocturia, I didn't see a lot of really out of control diabetes or really out of control hypertension in people who are symptomatic and presenting with Nocturia. And so I don't know how to reconcile that. I saw a lot of people with hemoglobin A1Cs that were 8.5 and 9.0, and we sent them back to their primary care providers in this clinical trial to come back with better control, and they came back and they still have the same Nocturia. I don't think that limiting nighttime fluids is great. I think that reapportioning fluids throughout the day is a meaningful strategy, but it seems like a lot of people have already come and tried to dehydrate themselves, and physiologically people are producing more urine at night than during the day. But otherwise, general H&P, looking for urinary tract infections, very unrare. Looking for sleep dysfunction, less rare. Looking for things that you can add multi-components to. Just one other quick thought is that I'm often worried about the trip to the bathroom and trip and fall. The pathway to the bathroom in older adults, and I feel that if I can get somebody to stay closer to bed with a handheld urinal or even a bedside commode or better lighting, I feel good about that.
Great. Do you ask people about how far how far that trip is, or try and get anything more about that?
Yeah, it's really quite often the negative history. I did a lot of asking about that, and just American home design, bathrooms are right close to the bedroom, and so that's often the case. Not always, of course, but in our interviews, it was every once in a while people tripping over the dog. It's like something that moves at night that you can't locate. Fortunately, our dog is white, and so I can usually catch her in low levels of light. I do have motion activated night lights all over the bedroom, and so whenever somebody gets up to go to the bathroom, then we got a better chance of seeing things.
Perfect. Well, we are at the top of our hour. That was just tremendous. Thank you so much. Really appreciate your time and expertise. This was really enlightening. So thank you.
My pleasure. I hope it was enjoyable and informative, and it certainly was a pleasure to interact with you all today. So thanks so much.
Fantastic. Thanks so much, Ted.